So, good morning. We're getting ready to start. And here's the thing. I don't have to tell most of the viewers of this channel the Tim Russert story. Tim Russert was a very globally renowned host of, I think it was Meet the Press. He was having some problems. He went to his doc. He said, hey, doc, why don't we just check on things? Why don't we get a stress test and make sure? They got a stress test. He passed with flying colors, did great, went back to work. April, May, June, 2 months later, maybe 3, had a heart attack, died in the office. So what's the purpose of a stress test? Well, the stress test will actually tell you a few things. It'll give you some information regarding your cardiovascular endurance. There is some relation between that and probability of heart attack, but it's not what most people think. Most people think, let's get a stress test and see if I'm going to have a heart attack. That does not work. That's what we're going to talk about in the program today. But before we go there, we'll cover a few words from our sponsor, who is us. Previous topics, for example. If stress tests are so important, why did they stop doing stress tests during COVID? They plummeted over the past year. Now, they didn't plummet. They didn't stop doing necessary surgery. They didn't even stop selling groceries. They didn't, my son works in the meat market. He's been going to work every day, but stress tests just fell off a cliff. We talk about that and why it did that. It might not be what you think. Go back and look at the video. The next one is a couple of videos on dentists. Why would we be talking about dentists? Because more people see their dentist than see their doctor. In fact, over 22 million people, according to a recent U.S. Census NHANES survey, saw their dentist and could have been diagnosed with prediabetes because they never saw their doctor. So, and what are we doing? The doctors are telling dentists, what are you doing, trying to play doctor? You don't need to be messing with prediabetes. That's the absolute wrong thing to do. And unfortunately, the dentists are listening. Way too often, the dentists are saying, okay, that's not my lane. It is your lane. You're a healthcare professional. Talked about intermittent fasting. We're still debating that in the science. And believe it or not, there's some plausible reasons for debating that. We've had plenty of others as well. For example, one of the more popular ones, the 5 different supplements for heart attack, cardiovascular health. Supplements are always very important. One of our important ones and popular ones had to do with triglyceride over HDL ratio. What is that? And why is that so important in terms of heart attack and stroke health? It has to do with prediabetes, diabetes. Speaking of which, the prediabetes, the Got Sugar webinar has become very, very popular. We're having to do it every couple of weeks now to meet the demand. There is a Thanksgiving special, by the way. And you can just call us or take a look at our website and you can find that. By the way, on the website today, we'll be talking about stress tests. If you go to the website, we cover it in the same topic in much more detail for those of you who like to read and who like to get more detail. For those of you who want to know about plaque, if stress test is not the way to find out if I have plaque, what's the best way? There are better ways, and we talk about that in that webinar. Pardon me if I seem to be shivering a little bit. It is just very cold in this room. There may be an HVAC reason, but I don't really mess with it because, it's good to become cold adapted. It helps you build brown fat for those of you who have an interest. And brown fat appears to be very, very healthy. Maybe we'll talk about that at some point. Those of you who are interested in supplements, we've got a supplements webinar. You can access all the webinars. You can access our subscription programs and access our courses, all right there on the website. Now, the book is coming out. The publisher has it. We've gone through selection of covers. And again, it starts out with that Tim Russert story, and it goes way deep into plaque. Why can't a stress test tell you about plaque? And what are some other things that can? And why is plaque so important? Well, plaque is very much related to heart attacks and strokes. Heart attacks are the number one cause of death. Strokes are the number one cause of disability. And yes, plaque is very much related, but again, maybe not the way you think. So head on over, take a look at the website. We had a huge increase in views. Went from less than 300 per month to over 6,000. We got stuck at 6,000, and it appeared to be a technical issue. So if you've been in, you tried to move around in there, and you found it to be slow, try it again, because just yesterday we migrated over to a higher volume system, a system that can handle these higher numbers that are coming in. Before we get into the major program, I just wanted to make a comment about what's going on with COVID. Dinner parties, game nights, casual American life. Those are the things that we've gotten used to these days in the age of COVID. You don't go out to movies and stuff like that anymore. Some people are going out to restaurants. That's a problem. But if you think about it and you start looking at where the contact tracing is leading back to, contacts for COVID-19, it's leading back to these small home events. Coronavirus's daily cases are surging beyond 150,000. We're hitting that second wave. Some people are arguing over whether it's a second wave or a third wave, but nobody's arguing whether the hospitals are becoming overloaded. Earlier COVID-19 clusters were linked to nursing homes and crowded nightclubs. Public health officials nationwide now say case investigations are increasingly leading them to small, private social gatherings, dinner parties, game nights, sleepovers, and carpools. Experts say this behind doors transmission trend reflects pandemic fatigue and widening social bubbles. This is particularly insidious because it's difficult to police and likely to increase as temperatures drop and holidays approach. According to David Rubin, the director of the policy lab at Children's Hospital of Philadelphia, small indoor gatherings create perfect conditions for a virus that can spread among people who are crowded into a poorly ventilated space. Social budget. According to guidance from the CDC, people should avoid spending more than 15 minutes within 6 feet of most other people within a 24-hour period. This came up on one of our recent webinars. One of the attendees asked me, what are you doing in terms of holidays? Well, here's the thing. We are getting very close to having effective vaccines available. It's like we're at mile 23, 24 of a marathon, which is, for those of you who don't know, is 26.2. And so many people train for that 20 miles only and then sort of hit that 20-mile wall. And a lot of people drop at 20, 22 miles. That's extremely unfortunate. And it can be deadly in terms of dropping from the marathon right now. We are not. Our daughter lives overseas. She usually comes back for the holidays. She's not coming back this holiday period. People also asked about travel. You know, I heard a great discussion about airplane travel recently. It was given by an infectious disease specialist who had done a lot of consulting for the air traffic or air safety commissions. And his perspective was, you know what? If the HVAC on these airliners had a slight variation, he'd feel very comfortable flying. But he doesn't. And for those of you who are interested in the science and the practical nature, here's what his concern was. He said, the engineering on these airplanes is built to where the air comes in from above and it gets pushed down. Now, that sounds good to a lot of folks, but when you actually consider what happens when humans exhale, it's the opposite. Humans are warmer than the air around us, so we exhale and we get a plume going up. So instead of creating a nice laminar execution where you get rid of that exhalation, which most people think is going on, you're getting turbulence. If it were to go the other way around, come from the floor and go up and exhaust, that specialist in this space said he would have gotten back on airplanes, but he's not getting back on them right now. So just food for thought. That item brings up one other thing. And I know anything regarding COVID is a political hot topic, but you know what? Sometimes you got to wade into political hot topics. It has to do with masks. There's been a theory for a long time called LD50. It stands for lethal dose 50. And what it has to do with is bacteria, viruses, other infectious agents. And the concept is that the smaller the dose of an infectious agent that you get hit with, the less likely you are to have serious disease. Now, that's based on an assumption that your body has more time to build defenses by the time the virus or other infecting agent builds up to critical levels. Now, I personally thought that that was very theoretical. I was skeptical of whether that actually existed, although there are clearly cases where you saw an LD50 type of mechanism. In fact, a lot of them. And there was another very interesting presentation I saw recently, which began to raise this question and began to attach it to masks. They quoted and described natural experiments for example, countries in Eastern Europe who were getting huge increases, who mandated mask wearing. And not only did the transmission slow down, the actual death rate for those infected slowed down dramatically. And if you look at the numbers, that's going on all over the world. The death rate for those getting infected is slowing down. Now, you could say, and it's true, we're getting a lot better treatments. We know a lot more about what we're dealing with once you get into the healthcare arena. But again, there's a lot of question coming up right now among the scientists studying this about that LD50 concept. Bottom line is, I've started wearing 2 masks instead of 1 when I go out. So in just a minute, we'll get to the topic of today: what you can and cannot learn from a stress test. So when someone we know has a heart attack, we worry about the possibility of having a heart attack ourselves. So we rush to the doctor and we ask, how about a stress test? A stress test is a procedure used to measure how the heart works while exercising. On a treadmill, an exercise bike, you can do it with drug induction as well. You give a drug and it causes the heart to beat fast. There are 4 basic types of stress tests. Drug-induced stress tests, they bypass exercise, as I mentioned. It uses a drug, usually adenosine, to stress the heart and cause the arteries to dilate. Stress EKG or stress ECG That is the original stress test. The patient walks for about 10 minutes on a treadmill and you get an EKG. You don't have the nuclear studies. Now, we'll talk about the nuclear studies in just a minute, but we show a clip of I think it's NBC News video about this topic a little bit later. You'll see a couple of numbers in there, which indicate that they're talking about stress EKG. The first is that it says there's only 3.5 million being done per year. The reality is in 2018, there were 8 million nuclear stress tests done and a little bit less than 1 million stress EKGs done in the US alone. Again, in 2019, I haven't seen the data yet. 2020, that number plummeted. The other difference, if you go to that link and you watch the whole video, you'll see it listed as $200 to $300. That's the other tip-off. That's a stress EKG, not a stress nuclear test. We'll talk about those a little bit further, and we can talk about them in the Q&A as well. Stress echo is also done. It's the same as a stress EKG or nuclear stress test, except that it uses a cardiac ultrasound or echo. Nuclear stress test is now by far the most common. There are 10 nuclear stress tests done for every one of the other types that we're talking about. Again, as I said, over 8 million were done per year up until 2020 with COVID. Instead of using echo, they do have EKGs as well, but they also use radioactive thallium tracers. So what can a stress test actually tell you? Well, according to the Mayo Clinic, and I have some issues with the Mayo Clinic, but we're going to go ahead and quote them on this topic. It shows how your heart works during physical activity. Well, that's true. It can reveal problems with blood flow within your heart. Well, that's true too. It may also guide treatment decisions, measure the effectiveness of treatment, or determine the severity if you've already been diagnosed with a heart condition. That's true as well. Diagnosis coronary artery disease. Well, if it's a positive test, it can help. It can help indicate the need for other tests, but there are a lot of false positives. Over 25% of positive stress tests are false positives. And as we'll show later on, it depends on how you define false positive and false negative. Clearly, at least 25% of negatives are false negatives as well. Again, back to what Mayo Clinic says, it diagnoses heart rhythm problems and guides treatment of heart disorders. Again, you start seeing me going a little bit like that. From Harvard Health, expert guidelines now discourage just-in-case stress testing. It's not 100% accurate. If stress testing were 100% accurate, everyone would have them regularly, and that's not recommended, but it's quite often done. It cannot absolutely rule out coronary artery disease or diagnose it. A quote normal stress test can't rule out the chance that a plaque will later rupture and block an artery. The U.S. Preventive Services Task Force urges physicians to stop routinely offering exercise stress testing. The tide has turned against exercise stress testing for otherwise healthy men, even men with risk factors. There are better tests. An exercise stress test is designed to find out if coronary arteries contain fatty deposits or plaque. And here's the key, that block of vessels 70% or more. You could still have a heart attack. In fact, most heart attacks occur in people with blockage less than 50%, which we'll get to here. Stress tests are the go-to measurement for arterial plaque. Unfortunately and ironically, stress tests don't measure plaque. They only measure blood flow. They can't detect plaque unless there is greater than 50 to 70% blockage of the blood flow. 86% of heart attacks occur in people with less than 70% occlusion, and 68% of heart attacks occur in people with less than 50%. So it's no wonder that the Tim Russert story happened, and all of us know stories of people that had a negative stress test, were greatly relieved, and then had an event. So heart attacks could happen even though a stress test won't show anything. Also, increased blockage does not correlate with the plaque's susceptibility to rupture. And that's what the problem is. A lot of this assumption about stress tests is based on the incorrect assumption that it's the amount of plaque that you have. And it's not the amount, it's the status of the plaque, whether it's inflamed or not. So if you look up accuracy of stress tests, you'll see a bunch of numbers. You'll see between 60 and 80%. You'll see nuclear stress tests as, quote, 80 to 90% accurate. But then start digging a little bit deeper and find out what they mean by accurate. And then ask the question, okay, well, actually, you can look it up, you can Google it. You'll see the snippet coming from, I think, one of the NIH references saying 1.5 million of those 8 million stress tests are known false positive or false negative. So again, you got to ask yourself, are you feeling lucky? Stress tests, like humans, make mistakes or errors too, and doctors label such errors as false positive or false negative. In Tim Russert's case, his stress test result was negative, which should mean he's negative for heart disease, which they knew was not the case. And again, unfortunately, was most likely interpreted as that he wasn't going to have a heart attack. However, we knew that he had come to a heart attack 6 weeks later, succumbed to a heart attack. So therefore, if you're talking about prediction of heart attack, clearly it was a false negative. And when you go back and you read about false negatives, false positives, and quote accuracy, this 80 to 90% accuracy of a nuclear stress test, again, dig a little bit deeper and find out exactly what they mean by accuracy. So again, as I've said maybe too many times, and you see it in general places for lay people like Harvard Health, a true positive does not automatically equate to a heart attack. And it doesn't necessarily mean that you need to have a stent, which doesn't prevent a heart attack either. They just indicate the presence of cardiac pathology. Now, as I said, this whole assumption that the stress test is the way to test for risk for heart attack is based on a mistaken assumption about how heart attacks occur. The assumption is that a heart attack occurs because blood flow stops because it is slowly squeezed off by plaque, growing plaque. That flies in the face of our experience every day where people have unexpected heart attacks. It's not a slow closing off. It's an acute event. By acute, I mean unexpected. I mean, by definition, who can predict when their heart attack's going to happen? That's because, again, the mechanism. It's not like hair clogging the drain of a shower or bathtub. Here's what it is. So this is the picture of an artery. On the left, you have an artery with no plaque. Each section has more and more plaque. As you get to the last three sections, what you see is that there's actually this bloody material, this liquid material. That material has immune cells in it. Those immune cells are releasing enzymes to dissolve that plaque. They also have things in there called cytokines. Cyto meaning cell, kine meaning attractant. Those extra chemicals, those immune cells, that inflammatory material, when it breaks through that very thin lining, that single cell lining called the intima, as is shown here, that causes a clot. If the clot's big enough and it goes to the heart, it causes a heart attack. If it's big enough and it goes to the brain, it causes a stroke. If it's tiny, as in microscopic, and it's happening all day, every day for decades, the microscopic view of the heart tissue can start to look like Swiss cheese, and again, even more commonly in the brain. That can result in heart failure or dementia. Now that was a diagram. Here are some real pictures of arteries that have plaque in them. This is that muscular layer. Let's go back and here's the intima layer, that lining I was talking about, and this is plaque. So let's go back and take a look real quick. That's the muscle layer that keeps your artery from bursting apart with these pressures of 120 millimeters of mercury. If you didn't have that that muscle layer, that pressure of the pulse would just blow this tube apart. Now, the real metabolic activities go on in this single cell lining called the intima. We've talked about that in the past, and we've gotten even deeper in terms of talking about the glycoprotein. It's sort of a mucousy, slick area, which we won't go into today, but just, again, to help you connect the dots. As plaque builds up, as our intima gets injured, most commonly from inflammatory processes like having too high a blood glucose for too long, or too high of insulin levels for too long. In 80% of people, that's what causes this intima to leak LDL into this area. The LDL won't go through the muscle layer, it just gets stuck there, and that's what's called plaque. And that's why plaque is made up of LDL. And because it was made up of LDL, people thought for a long time, well, you are what you eat, so don't eat cholesterol. LDL stands for low density lipoprotein, which is mostly cholesterol. So you get this buildup of this LDL in this area. Your immune system notices that and says, look, we've got to clean this out. It goes in, releases in, creates more, attracts more cells. Those cells release more cytokines, more inflammatory chemicals, activities, and again, that's where you get this inflamed plaque. So this is the intima. This is that muscle membrane, muscle support layer. It's called the media, and this is plaque. Now on this one, you see, you've got this area right here that is sort of pushed back away from the slide surface. That is inflamed plaque. That's a liquid area. And as you see, it's right under the surface of the intima. So here's what happens next. In this is a large scale, what we call a gross, meaning you can see it but with the naked eye. Preparation of a slide of a patient that died from a heart attack. This area out here is that muscle layer, the media. This is that intima, that lining that we talked about. And here are two places that had this hot liquid plaque. Here and here, a small one up there. This black thing is not hot liquid plaque, it's the clot. So as you can see here that the intima cracked, the liquid plaque flowed out into the bloodstream. You had a clot. The clot actually formed also back up into this area that was opened up by the crack in the intima. This is part of the clot, and the bigger part of the clot is what killed the patient. It broke off and went to the heart. So we'll do a quick review from somebody else on this issue, and then we'll go to questions and answers.
We're back now with that new alert about cardiac stress tests. Millions of Americans get them every year, perhaps even someone you know in your family. Some of the nation's top heart doctors are saying those tests can often be wrong, leading to sometimes painful and expensive consequences. So the question is, who really needs one, and might they not be necessary? Here's NBC's Ann Thompson.
The cardiac stress test. monitors blood flow for potential blockages. But Dr. Stephen Nissen, one of the nation's most respected cardiologists, says the test is often unnecessary.
Too many people get stress tests.
Stress test numbers are skyrocketing from 1.6 million 2 decades ago to 3.8 million.
What harm could a non-invasive test cause?
It's important to understand that stress tests are not very accurate. They're going to lead to other procedures that are more expensive, more invasive, involve more risk, and more consequences.
So I get back to that last question, that last comment, that last scene. So these are relatively harmless, these stress tests, right? Yes, they are. But what's the next step if you have a positive stress test? You go to the cath lab. And guess what? When they sign you up for consent to go to the cath lab, they usually will sign you up to say, look, we may find plaque in there and we may need to do a stent. So why don't you just go ahead and sign off on the stent while you're here? Somebody was talking to me at one of the webinars recently, and he said, Doc, I got to challenge you a little bit. If you're on the table and they tell you you need a stent, what are you going to do? Start quoting some doc on the internet and say you don't want a stent? No, you can't do that. And in fact, for a whole lot of people, they're already under the ether and they never wake up. They went in for a cath and came out with a stent. So why are we going where we're going? That's why we start with the stress test. It's what I would call the unholy triumvirate. It's stress test followed by a cardiac cath followed by a stent. And again, that gives you a false sense of security if you think that process is going to prevent your next heart attack. The processes themselves, you could argue how dangerous they are. You know, the reality is, if you look at the statistics on the dangers of getting a cath, you know, you're putting a needle into the artery, the femoral artery in the groin. You're threading it up through a catheter, going into the heart. But the reality is, it's not that dangerous. Believe it or not, this will sound weird, and it maybe is, but I know of a couple of cardiologists, interventional guys, who got very curious about it, and they both felt strongly, like I do, that the best doctor experiences everything he or she can regarding what their patients are experiencing. Yep, you can guess where I'm going with this. One of them hopped up on the table and even though he had no problems whatsoever, and let the other guy do a cath on him. Was that totally crazy? Believe it or not, I think you could argue whether that was. But again, then the cath leads to a stent. Both of these processes lead to a lot of radiation. And most of all, unfortunately, they lead to a false sense of security. So that's the concern. And that's why we go back to the original tripwire event. Think twice before you even go there in terms of getting a stress test. So let's go to a couple of comments. Bart, good morning, Dr. Brewer. Looking forward to this topic. Thank you. Baterio723, 2020 has been a stress test in and of itself. Wait till 2021. That's the truth. It has been quite a year. A lot of people seem to be giving up, though, just a short time before the vaccines become available. It's like giving up the last 2 miles of a marathon, which happens all the time because, as I said, people tend to train for up to 20 miles and then stop. I'll get back out of marathon mode and talk about this. As I would have guessed, anytime you bring up something like a vaccine, be ready for the political junk that's going to start coming our way. Good morning, John Tocho. Thank you for the comment. Thank you for joining. And John says, Dr. Brewer, I've become more cautious as we get closer to the finish line with the vaccine. I don't want to be one of the last casualties. Me too. Thank you, and I agree. Amer from Germany. Good to hear from you. My BJJ, good to hear from you. From Temecula, California. I hope I'm pronouncing that correctly. And BJJ stands for Brazilian Jiu-Jitsu. Nancy Salvaggio, is a stress echo the same as the stress test you were talking about? Well, Nancy, I don't know if you were on. You can hear the replay if you weren't, but we talked about the different types of stress tests. There's the stress EKG, the stress echo, which is an echocardiogram, and the nuclear stress test, which uses, again, thallium radionuclide tracers. Bart Robinson, good morning to all viewers. Thank you very much, Bart, for your interest and support. Kay King, good morning, Doc, from Central Texas. Thanks for mentioning where you're from. Jeffrey Beagle, I have a stress test coming in a few weeks. Well, I hope that this helped provide you a little bit more critical information regarding what you can expect from it. Art Berry, I had two brothers who passed from sudden cardiac death events. Both were age 59 at the time that they passed, and both had previous stress tests that year. Seems like the test isn't the gold standard. It isn't. Now, what is? I'll use this opportunity to dive into another area. So if you get the book, one of the reasons for covering these items is to prep you guys in the subscriber and viewer population for the book that's coming out. Here's what the overall overview of the book is: to talk about that triumvirate stress test leading to a cath, leading to stent or bypass graft, and the problems associated with that. It then tells you, it doesn't just leave you with that problem, though. It doesn't leave you hanging. There are actually better ways. And it talks about three of them: CT angiogram, calcium score, and CIMT. And we go into, well, book level detail on all of those. We also talk about the Framingham. You know, you could say it really doesn't start with stress tests, it starts with Framingham. And Framingham is a town, an hour or two from Boston. And it's where it's been an ongoing multi-generational cardiovascular epidemiology community study. And there's a thing called the Framingham calculator, risk calculator. So when you go in, your doc is basically just doing the Framingham on you, whether he actually tells you that or not. He's looking to see your age, your gender, ethnicity, risk factors such as smoking, BMI, things like that, and doing a calculation on what the probability is of you having a heart attack over the next 10 years. If it's over 5%, 5 to 10%, 5% is the usual cutoff. Other people use a 10% cutoff. Then they start talking about things like, again, usually statins or a stress test. That's one of the reasons that a lot of people are put on statins that probably shouldn't be. The Framingham study's based on data that's over a decade old. And it grossly overestimates heart attack risk, especially in women. It almost doubles that for a lot of age groups with women. So again, if you're getting put on a statin, especially a high-dose statin, and it's based on the Framingham, think a little bit more about that. Question your doc, investigate that a little bit more. Thank you, Art, for giving me that opportunity to go down that bunny hole. John Tocho, deaths in Minnesota for COVID are still at a rate of 80% plus of total deaths for those aged 70 and above. Most of those are in nursing homes. Thank you for sharing that. We're getting a lot of comments right now, so it's I'll try to get all of the comments. Sometimes it skips over them, especially when you start getting a lot of them. Herb Houston, but what's in the vaccines? I've read blogs so they talk about tissue from aborted babies and nanotech and dangerous preservatives. And yes, Herb, if you believe that, I don't know what else to say about that. I remember that a very small percentage of the air is filtered. I've also read the virus is 3 times smaller than the pores of the masks that are used. So therefore, don't use a mask. If I'm assuming that's the assumption from both of your comments, Herb, don't get a vaccine, don't use a mask. That's your choice. Do so at your own risk, my friend. BJJ, do you believe that stress tests are used for attempting to elicit symptoms for those with aortic stenosis? Generally, surgery is not done until symptoms, but many are unaware that until they are pushed. Yeah, so it's a good point, and I'm actually not going to go there. It's a very, very different point, though, from what most of us are complaining and trying to warn people about. This assumption that I can get it to rule out heart attack, and I need to be getting it on a routine basis. Those are the places where it really piles up. When you've got a specific condition like that, it becomes somewhat a different issue. It's a good point, BJJ. Thank you so much. John Tucho, smash the likes and think about joining Patreon. Thank you so much, John. I appreciate that. For those of you who are wondering what he's talking about, Aspen and Gilbert have that up at the top here, and every little bit helps. You know, our goal is to wipe out heart attack and stroke, or at least pull them back off of the number 1 and number 2 places that they have for death and disability. You can help. So, Heather Armstrong, what causes the bottom number of blood pressure readings to be over 100 when the top number is around 130 to 140? And what would you recommend for blood pressure around 140 over 100? That's a good question. Now, I could talk for, gosh, hours and hours and hours about what causes elevated blood pressure. And I won't do that. I'll spare you from that. There's a whole bunch of things. I personally think that one of the, and here's the other thing. The vast majority of blood pressure, high blood pressure that you see in the country is labeled, or you see anywhere, is labeled idiopathic. Idiopathic just means we don't know what causes it. It's not proven. Now, I will tell you this, it tends to go right along with aging and right along with metabolic syndrome, prediabetes. There is clearly a mechanism where AGE, advanced glycation end products, appear to clog up the pressure gauges in the kidneys. You know, each kidney is about 1 million filters. It's microscopic filters, obviously, and they have some recollecting tubules in there as well. So as you see, it's a major plumbing miracle. And in that miracle, you have some adjustment factors to increase the blood pressure if they're not getting enough flow to do proper filtration. Those sensors, those thermostats tend to get clogged up by things like, I mentioned AGE, not aging, or it's associated with aging, but advanced glycation end products. And you remember what the most common AGE is? Hemoglobin A1C. It is glucose, a protein that has been covalently bound, in other words, permanently bound to hemoglobin to glucose. So that's something to be thinking about. Now, you'll hear a lot of, if you Google AGE, advanced glycation end products, Most of what you'll see on that really has to do with food. And there's this perception that, again, you are what you eat, so don't eat food. Well, one of the most common sources of AGE, glycation end products, is in barbecue and cooked meats. I'm not going to get too deep into the whole vegan versus non-vegan dietary debate right now, but I will say this. Most of those, at least from what I've seen, most of those, I think this concern about dietary AGE, glycation end products, is probably similar to the concerns that we had a long time ago about cholesterol in your diet causing cholesterol in your arteries. I don't know anybody that's trying to argue that anymore. And I think my personal perspective as a medical scientist who's looked at this is that I think we're going to find the same thing about ingested AGEs. I don't think that's the issue. I think it's the AGAs, the glycation end products that we create with our own body. So thank you for the question. Anna Daniel Alif, I'm supposed to get a stress test where they're giving me medicine to make my heart race. That was the adenosine we talked about the day before, and giving me something then, and I got to go eat and come back, and is these tests safe? Well, I think we just talked about it. I think the biggest risk of these tests is if they're negative, they give you a false sense of security, because 2/3 of the people that have heart attacks will pass these and not have a problem, just like Tim Russert did. There is another side of danger, and that is if you get a positive, then you go to the cath lab, and when you're in the cath lab, you may sign up to get a stent. And again, stents aren't really that dangerous either, but you're messing around with the arteries in your heart. And 90% of those are put there because you have plaque. 90% of those are put there to prevent a heart attack. And we've shown multiple times they don't prevent heart attacks. Now, they may have a positive impact on angina, although, and I'm convinced that they have in some cases, although you look at some studies, there are other studies that would also indicate they really have relatively little impact on angina as well. And yes, I know, every time I mention that, I get a lot of hater comments. I'm not telling you that your stent did not help. I'm just telling you what's in the science. And when that last comment was not directed to you, Anna, it was directed to the hater comments that I'm going to get. Every time I make that, that comment that the science indicates that stents don't even prevent angina, I get a bunch of hater comments. So again, for those of you who want to tell us that, I know there are plenty of people out there who feel very strongly that their stent did prevent their angina. And you know what? I believe a lot of folks are right. I believe in certain cases they do end up helping significantly with angina. But if you look at it over an overall case, it's not nearly what you would think. Jonathan Hull, hi, Dr. Brewer. I understand that CAC, coronary artery calcium score, CIMT, and coronary angiograms are alternatives to a stress test. Is that correct? Is the angio an invasive procedure? Well, Jonathan, you got 2/3 of that correct. And you could technically say, well, a coronary angiogram is an alternative. Here's what I think you meant to say, CT angiogram, because that is the third alternative. Again, as Jonathan's saying, coronary artery calcium score, CIMT, and CT angiogram. Now, what's the difference between a coronary angiogram and a CT angiogram? In the coronary angiogram, that's where you go into the cath lab, you get the needle in the groin, the catheter up to your heart, they inject the dye, you get a lot of radiation and a lot of pictures. On the CT angiogram, you don't get the needle in the groin, you get a needle in a vein. They do inject some dye usually, and again, also radioactive dye. And they give you what turns out to be a great picture of of plaque or lack of plaque in your coronary arteries. Now, if you look at things like the Scott Hart trial and a couple of others, I'm blanking on the name of the other one. I don't think it was the Courage trial. But anyway, if you look at some of the trials that have had CT angiogram, what they found was people had clearly, well, they did like a randomized trial. They said, you know what, do what you usually do, doc. Or, well, there were two groups. In both groups, they did what they usually do, which is usually going to be a stress test. In the test group, they also did a CT angiogram. In the control group, they did not do the CT angiogram. Here's what they found. It was like over the follow-up for about 5 years. In the beginning, the people that had a CT angiogram, as you might guess, they found out that they had a lot more plaque than the people that just did the stress test. And in the beginning, they had a couple of more procedures. But if you looked out over the full 5 years, they didn't really have any more procedures or anything else done to them than the people that didn't have the CT angiogram. Yet, the people that got the CT angiogram lived longer. Now, why would that be? Well, logically, you have to say, well, it's not the procedures, because overall it was the same number of procedures. I will tell you what my patients that have had CT angiograms tell me. They say, doc, the pictures I get when I get my CT angiogram, the images are just striking. I now know that I'm not, quote, free from a heart attack. I'm not safe. I've got plaque in my arteries, in my heart. So a lot of them will just go ahead and tape a picture of that CT angiogram image on their refrigerator. Nothing like motivation to change your diet, huh? Great question, Jonathan. Thank you very much. Bob Bell, oldest brother passed a nuclear stress test with flying colors. He had a 5-way cabbage days later. No trust in stress tests. Bob, thank you so much. And those are the others who have shared these stories. We all know these stories. We all have them. It's very different, though, when you hear some doc on the internet stand up and talk about it versus hearing real people, real patients who have real relatives, real brothers and sisters and uncles and wives and husbands for whom this has happened. Thank you so much. Bob, if you considered a CCTA, then ask for a FFRCT to ascertain if there are blood flow problems without being invasive. Thank you, Bob. I'm not going to get, Bob is one of our more informed and more technically savvy viewers. Thank you for the comment. Trobolt 1, thank you. Well, Trobolt 1, you're very welcome. Thank you for your interest. Hot Wheel 66, I hear stories all the time about guys with blocked arteries passing a stress test, ? Well, we all do. And here's the, we just went over the reasons why. Uriel Wong, good to hear from you, Uriel. Thank you so much for the comment. Sometime you'll have to tell us what the spider's for. Anna Daniel Alif, so should I do the tests? And thank you so much. God bless you and all. Love, hugs, and the sweetest blessings and so much more. Anna, I can't give individual medical advice to someone who's not my patient. If you want to become a patient, you can call. I'll give you the number. It's 859-721-1414, I think. It's on our website. I'm still open for seeing patients. We are getting, I will tell you this though, we are getting more and more activities, and we're going to be bringing on some other docs. We've got some great docs who know this space very, very well. One of them's already been on the channel. His name is David Wright. Another of the docs that's that we're talking to right now has also been involved. He actually has done a lot of comments. He's a frequent frequent viewer and frequent commenter, Kevin McCord. So we're having some meetings actually tomorrow to talk about increasing our physician staff just because there's demand, and that's great. See with them. I just had a cath a month ago. They found 100% occlusion in the very bottom of my LAD, and that stands for left anterior descending. It's also called the Widowmaker. I had developed my own bypass naturally with, quote, collateral circulation, end quote, fed from my lower right artery. That happens all the time. So it's like we continue to think that things are far simpler than they actually are. You see this all the time where it's called collateral circulation. The tissue has a way of demonstrating, hey, I need more blood supply over here, as it can, and it releases some chemicals like lactic acid and other things which stimulate the growth of blood vessels to tissues. Thanks for that comment. Let's see. Trobolt 1 scares them into a lifestyle change, maybe. Yep, that's what the goal is. As you might guess, in my space, I'm not a mental health is involved. I'm not a mental health provider, technically, but I get a lot of grown middle-aged men in a generation where crying was not accepted, come to me and start crying because they start talking about calcium score over 3,000, things like that. Once you get involved, once you start looking at these things, once you start realizing what to do, it's like a huge burden lifted off your shoulders. You don't have to have a heart attack. You don't have to have a stroke. Even if you've had a calcium score of 3,000. And that's just reality. Thank you, Trobo, for the comment. Chosen One, I had an echo a month ago, was experiencing chest pain, mitral valve prolapse. Does that mean I could have blocked arteries? Well, mitral valve prolapse, again, talk about complicated issues. Mitral valve prolapse can even cause heart symptoms, even like pain in young, healthy people. And so no, it doesn't. That doesn't necessarily mean you've got blocked arteries. What I would do is coronary artery calcium score, CIMT, CT angiogram, depending on what's going on. The radiation from the first two, the calcium score and the CIMT, is negligible. There is no radiation in CIMT. It uses ultrasound technology. For that reason, there are CIMTs done on children when they come out of the womb. Believe it or not, you can see plaque on children coming out of the womb. And guess when that happens? When the mother had diabetes at pregnancy. So again, this starts early. CIMT has a couple of advantages. One is that you don't have the radiation. The other is that it'll actually show that soft plaque. Remember, in one of the images early in the presentation, we talked about soft plaque. You don't really see that in any of the other technologies very well. You do see it with CIMT. What's the downside on CIMT? It's very hard to get it right. The vast majority of people that bring in CIMTs to me from their local hospital, it wasn't done well. And why? I can show you why, but I'd rather not go down that bunny hole today. There are some good providers in the country, and we can help you find them if you'd like. Thank you so much for your interest today, and we're going to sign off.